In this case, arthroscopy has the role of evaluating the correct reduction and evaluating if there is ligament injury. But with arthroscopy, in cases in which it doesn't reduce easily, we can reduce with a probe the medial fragment while fixing it with a key wire or with a screw. Ricardo?
Hello. Hi, Mia. Ciao.
Hi, Ricardo.
He's the master. He's the master.
No, I'm just a surgeon.
Yeah, huge honor to have you here.
I want to say that when I do the arthroscopy of the TM joint, I don't use 4 kilograms. I use only 1 or maximum 2 kilograms because it's too much for one small joint, and this is enough to opening the space and reduce the fracture. Another trick is I used to, before using the screw, I use 2 key wire. Both blocks the fracture. Then I remove one, I put the screw, and then I remove the other one key wire, and then I put the last screw.
Hola a todos y bienvenidos a las charlas con el autor de la rigma. Hoy tenemos la suerte de tener a Lucian Marcovici. Él es un experto en artroscopia de mano y muñeca, es italiano, trabaja en el hospital israelí de Roma. Y nada, a todos vosotros os recomiendo que lo sigáis en redes sociales, a los que no lo conocéis, porque la verdad es que cuelga casos muy interesantes. Es un tipo interesante. Lucian, do you understand Spanish? Or do
Yeah, it's very similar to Italian, so I can understand what you say.
Okay, I ask you the questions of the room in English, or I could ask you in Spanish.
We try
Okay.
also in Spanish. So
Yeah. Okay, because maybe for someone it's easier if we talk.
yeah, no problem.
The speech it's going to be in English.
In English.
Yeah, because it's easier for you, and
Yeah.
we are here to learn from you. But if you wanted, and we could try it, we could do the questions in Spanish, and you
No
could
problem, no problem.
Okay.
So I will speak about the arthroscopic assisted treatment of trapecio-metacarpal joint fractures and malunions. And I will show you the treatment technique that we described in 2021 with Riccardo Lucchetti. And I will show you some nice cases and how the technique evolved and is still evolving in all kinds of trauma of the trapecio-metacarpal joint.
Okay, so sounds great. So
okay.
Go ahead.
So the first thing, I want to invite all of you to the Italian Hand Society meeting. This year it will be held in Rome in November, and you're all invited, and we'll be honored to have you as speakers. You can download the application and subscribe to the meeting. There will be session in Italian, and if there will be a lot of Spanish-speaking people, we can do also a session in this language.
That's perfect.
Yeah. So when speaking about fractures of the base of the first metacarpus, we need to understand the trauma mechanism, and most of the time it's a direct trauma with the hand stretched, and we have the ligament, the palmar oblique ligaments that have an important role in strapping off the bone from the base of the metacarpus. And then we have also the muscles that play an important role, the adductor pollicis and the abductor pollicis longus, especially the abductor pollicis longus may also strap the dorsal part of the bone, and in this case it will be a Rolando's fracture. So traditional way of treatment of this kind of fractures is with a simple traction and a percutaneous fixation in case of very fresh fractures. But We know that when time passes, these fractures don't really reduce easily. And if there are more fragments, like Rolando's fractures, open surgery is needed. And open surgery means that we are opening the capsula, we are taking away the tendons, opening the capsula to see the joint. Those are articular fractures, and we need to see very good the joint in order to reduce the fracture. And then we will use most of the time a stable fixation like a plate. And we know that the plates in this case are then under the tendons, and these cases are associated with rigidity and risk of tendon laceration. So we know that arthroscopy has gained a lot of popularity in wrist trauma, and in wrist fractures there are a lot of articles that are speaking about the advantage of arthroscopy in evaluating the reduction of the fracture, in reducing in a mini-invasive way the fractures, in evaluating the stability of the fixation, and in evaluating associated ligament injuries. That is why in 2021, we thought it's very important to applicate also a mini-invasive arthroscopic assisted treatment to the fractures, to the articular fractures of the metacarpal base. And we published our technique. So to understand how to mini-invasively treat these kind of fractures, we need to know the anatomy of the trapecio-metacarpal joint, but not only the bone anatomy, also the soft tissue anatomy. It's very important to know that we have our arthroscopic portals in a relationship with important structures like the dorsal branch of the radial artery, or the terminal branches of the radial sensitive nerve, and also with the tendons, the tendons of the first extensor compartment and extensor longus pollicis. It's also very important to know the capsule ligamentous anatomy. I think this research of Mireia from the Kaplan Institute in Barcelona is very interesting, and was very mind-breaking. She described actually how the ligament groups are in relationships with the arthroscopic portals in the trapecio-metacarpal joint. And I found this article very interesting when approaching arthroscopically this joint. And we know that there are dorsal ligaments, volar ligaments, and ulnar ligaments of the trapecio-metacarpal joint. And we know that the dorsal ligaments are the main stabilizers of the joint, and the volar ligaments, especially the anterior oblique ligament, are very important in the mechanism of the creation of the volar fragment in articular fractures, so in Bennett fractures, but also in Rolando's fractures. The ulnar ligaments are also important because the intermetacarpal ligament connects the first and the second metacarpus, and the interruption of this ligament can create a dislocation of the first metacarpus. So we really need to know what kind of arthroscopic portals we have in the trapecio-metacarpal joint, and what every portal can give us in the meaning of visualization inside of the joint. So everybody knows the 1U and the 1R portals. Those are the two main portals in the trapecio-metacarpal joint. Those portals are in line with the ulnar and radial border of the nail, of the thumbnail, at the level of the trapecio-metacarpal joint. But we have also other important portals: the radial portal, described by Orellana, and the tenar portal, described by Walsh. So it's important to know that the 1U portal gives you a good visualizations of the volar ligaments and the dorsal ligaments. And the 1R portal gives you a good visualization on the ulnar ligaments and the dorsal ligaments. Okay. The radial portal and the terminal portal are very useful when managing the fractured fragments. They are in the good position to use our tools to reduce these fragments, and I use those portals for the reduction. So they are good working portals in trauma of the trapecio-metacarpal articulation. So when we describe the article, our main indications for the arthroscopic mini-invasive treatment were Bennett's fractures, Rolando fractures, and pending malunion of those fractures. But you will see during the presentation that with time, we started to apply the arthroscopic mini-invasive treatment also to associated trapezium fractures and to treat the associated ligament injuries. So there is an evolution in our way of treatment in this kind of trauma. So when treating trauma, when treating a fracture with arthroscopy, the arrangement of the equipment in the operation room is very, very important. We need to organize everything in a correct way to work easily. It's very important to use traction devices that permits you to work dorsally and volarly, okay, to access the articulation for 30-60 degrees. And I use sterile traction devices like this one, but Ricardo uses traction devices that come from the shoulder, and they both permit us to work all around the TMC joint. Another important setting is that the surgeon works in front of the joint and the assistant is in front of him and keeps the hand in supination, stabilize the hand in supination. I also like to work with a small C-arm device. I think it's much more easier to watch the fixation while I'm doing arthroscopy. It takes less space. So if you have it, it's really wonderful. So let's go to the practical part. So all the portals that we use give us a good visualization and a good possibility to work all around the articulation. And this respects the box concept that was introduced in the wrist with Bain. And we actually applied and created the box concept in the trapecio-metacarpal joint. In case of Bennett fractures, we have a volar fragment, a volar articular fragment. And we know that in acute fractures, in very fresh fractures, the traction throughout the thumb will reduce the fragment. And we can actually do a fixation after a simple traction. In this case, arthroscopy has the role of evaluating the correct reduction and evaluating if there is ligament injury. But with arthroscopy, in cases in which it doesn't reduce easily, we can reduce with a probe the medial fragment while fixing it with a key wire or with a screw. So how do we fix these fractures? So the easiest way to fix a Bennett fracture is with key wires. Okay, it's the most economical and easy way of fixing this kind of fractures. As we use arthroscopy, we can control the anatomical reduction, but also the stability of the fracture. So we actually never block the trapecio-metacarpal joint. We leave it always free. If we treat it with a key wire, or even if we treat it with a small fragment screw, like in this case, we always leave the articulation free. A fixation with a small fragment screw is more challenging, more demanding, and requires practice and experience with small fragment fixation and with arthroscopy. This is the result of 3 months of the patient, which was treated by a screw. We can have also a situation in which we find out during arthroscopy that there is no single fragment for a Bennett fracture, but actually it is a comminuted fracture. So this is the first fragment that I saw, and I tried to reduce it first with a freer, and then I used the probe to position it in the right position. And then I used a key wire, a small key wire, to fix this small fragment in place. And then I started to work on the main big fragment. So there was a second fragment, which I reduced with a freer. And after the anatomical fixation, I used other 2 key wires to fixate it. And this kind of fracture did not reduce by a simple traction. So I needed to reduce it only under arthroscopy. And I checked the stability of the fixation. And this is the X-ray of the fixation. You can see that the medial fragment was reduced anatomically by 3 key wires, but actually it was not so easy because it was comminuted. And this is the clinical result of the patient at 3 months. You can see that he has movement which is equivalent to the other side of the head. In case of Rolando fractures, the reduction mechanism is different because the traction throughout the thumb will reduce the volar fragment, but actually will dislocate even more the dorsal fragment, which is connected to the APL tendon. So it's very important to first reduce the dorsal fragment before traction, and only then do traction and reduce the volar fragment. But this is true only for fresh fractures, because even if the fracture is at 10 days, it will be very, very, very hard to reduce both of the fragments with the simple traction. And actually, we also describe how to treat this kind of fracture when it goes in pending malunion. And I will show you a pending malunion of a Rolando fracture. Okay, you can see both fragments which are dislocated, and then they are fixed in this dislocated position. In arthroscopy, you can see the different level of the fragments, and we are in traction, they don't move. So the first thing that we do a debris of the scar tissue. Then we put a small freer inside the fracture line, and we interrupt the fibrous callus, and then we mobilize the fragments and reduce them to level them up, and we can then fix, in this case with key wires, the fragments, and check the stability of the reduction, the anatomically reduction of the fragments. And again, we can see it, freer is used to put it inside the fracture site to interrupt the fibrotic callus, and is used also to mobilize and anatomically reduce the fragments. And again, we see that first in the sequence, first we fix the dorsal fragment, and then secondarily, we go and fix the volar fragment. And this process is very important to get a good reduction and a good stabilization of the fragments. And this is the result. As you can see, even in this case, we don't block the joint, because we are sure of the stability of the fixation. So I presented this technique in the international meeting, the IFESH in London in 22, and I spoke a lot with Fabio Tendioi, which is a great friend of mine from Colombia, is a great hand surgeon from Colombia. And we spoke about the application of the technique even in trapezium fracture. And then we spoke a lot about it, and we had a case. Fabio had a case of a trapezium fracture, and he applied this technique. And I will show you. You can see that he had Bennett fracture. He actually diagnosticated Bennett fracture in X-ray. He didn't. There was no evidence of trapezium fracture, but with arthroscopy, he saw that there is also a fracture of the trapezium, and that permitted us to use the same principles in fixing also the trapezium fracture. So we used a needle to give the good direction for the screws, and then we fix it with 2 screws. So we fixed the Bennett fractures, and then we went and fixed also the trapezium fracture. And then we checked the ligaments, and checking the ligaments is also a very important advantage of arthroscopy. So arthroscopy gives you the advantage of doing a reduction, controlling the stability of your fixation, doing diagnosticating also an associated fracture, like in this case of the trapezium, but it gives us the possibility also to diagnosticate a ligament. And sometimes in very important trauma of the trapeziometacarpal joint, you can have also an associated ligament injury. So this is the patient after surgery. Also in this case, we don't block the trapeziometacarpal joint, and you see that it's stable and it's good. And then we we evolve even more in our method of treatment, and we started also to treat dislocations that are associated to fracture, or even if they are not associated with fractures. So we started to do a repair of the ligament, do a reinforcement, a capsulodesis of the ligament under arthroscopy. And this technique is going to be published soon, and you can see how by an anchor which is placed on the base of the metacarpus, we are doing a reinforcement of the dorsal ligaments to treat a dislocation of the trapeziometacarpal joint. So you saw in the presentation an evolution of our way of thinking, of our way of approaching this kind of trauma of the trapeziometacarpal joint. These patients, the patients with fractures, are immobilized for 30 to 45 days with a thermoplastic splint. But actually, since day 1, they can take off the splint and do exercises that are being taught to them by a hand therapist. And actually, they start the movement since day 1 after surgery. So this is our experience in fractures, in arthroscopic assisted treatment of the fractures. These are our casuistics in 2 centers. So my patient and Riccardo Lucchetti patients. And as you can see, most of the patients are young patients. 11 patients were athletes, and in 15 patients, the right dominant hand was involved. So as you see, those patients have a great benefit from a mini-invasive approach, like the arthroscopic approach. Most of the time, we use key wires. And sometimes we use the screw to fix the fragments. So all patients in our series demonstrated a complete consolidation, and range of motion was equivalent to the contralateral hand, and all patients returned to their previous work and sports activities. So you can see the involvement of our research group from the arthroscopic treatment of fractures to the fractures of the base of the metacarpus, to an arthroscopic treatment of fractures also of the trapezium, and to an arthroscopic treatment also for ligament injuries which are associated with the dislocations. So my take-home message is that all articular fractures of the trapecio-metacarpal joint are amendable for an arthroscopic assisted reduction and pin fixation or internal fixation. The advantages are of a minimally invasive method. The fragment reduction is under direct visualization control, and we can control also if there is a ligament injury associated. The patient had the benefit of an early postoperative rehabilitation from day one after surgery, and this contributes to their gain, their impressive gain of range of motion. And the relative disadvantage of the technique is that technically it's difficult to start with. Okay, you need experience with small joint arthroscopy, and when you need an experience with small joint trauma, mini-invasive methods for small joint trauma. But with an appropriate learning curve and experience, it's an amazing method. So I thank you all for the opportunity that you gave me to show our experience and our methods of treatment for the trapecio-metacarpal joint trauma. Thank you.
Thank you. Thank you, Lucian. Here you have the email of Lucian. So try to share again.
Yeah, wait.
Because if they wanted to obtain the papers, maybe they could write.
Yeah, absolutely. Wait, I will show you again.
So you are showing plenty of papers. So I think that it's important that they have that they are allowed to achieve it. So I have some questions.
Yeah, absolutely.
So are you using the scope is 2.0?
So we use normally in the trapecio-metacarpal joint, we use a small scope, 1.9 most of the time. There are some scopes, some people uses 2.4. It really depends in how how distended the scope the joint is. With 1.9 scope you can easily enter the joint. With 2.4 it's not so easy, okay, but it's more difficult. You cannot enter in every joint. Some are really closed.
Yeah. So at the beginning of the arthroscopy, are you using water to distend the joint or not?
So you know, the Italian school is very similar to the Spanish school. So we use only dry. But dry. You know, we do dry arthroscopy, and but actually it's if you need to wash, you use the water to wash the fragments or the hematoma, and it's not a problem, you know. It's not, the problem is not using the water, but I think that when you work dry, you can see the tissues really at their natural state. You can evaluate very good the ligaments. You don't have the synovia floating, and you can also manage very good to the fixation.
Yeah.
You don't have water that goes out of the portals.
Yeah, totally agree. But it's true that sometimes if the joint is very close, so I need to start with water just at the beginning, and after that, when I am inside, so it's easier. But sometimes
water is not the problem, you know. We are still there are still a lot of question of do you do it wet or dry, and I think all the people that does dry arthroscopy uses water in some phases to clean or to distend at the moment, but we can discuss about when using the water. But the advantages of doing the fixation with the dry method is incredible. And in the wrist, it was a totally change of the duration of and the difficulty of the operations.
Yeah, so for the swelling of the tissues.
Absolutely.
Yeah. So I understand that you are using mainly key wires over screws.
I think it's easier. Okay, so we work in the public system,
Yeah.
so it's easier for us using key wires, and it's also much faster. Okay, and I think it's a good it's also a good message for people all around the world that even experts uses key wires without any problem, and they have also good results. You know, you don't always need to use fancy costly things. You know, key wires are a good solution a lot of times. You know, when you have small fragments, a small key wire will save you.
Yeah.
You know, so
No, it's true. And sometimes I have the experience that when I am using screws, so you should be very accurate, because sometimes with this kind of screws, so if you don't drill the second cortex of the piece of bone, so you are pushing, not
exactly.
compressing, you are pushing the fragment, and when you have perfect reviews, so you are going against your your movement, so it's not easy to use
No, I think it requires a lot of ability. Using a small fragment screw is very, very challenging, because you need to push it in the right direction, and you need to have a very good screwdriver. It makes the difference. It's not so much the screw, how the screwdrivers it makes the difference. You need something that helps really good the screw.
Yeah. And are you using cannulated screws or
So if I use screw, I prefer nowadays cannulated screw. You can have them at 2.0s, and there is also some companies that are working on 1.7, and it makes
yeah,
the difference. But again, also with cannulated screw, I think that you need um, to drill both corticals, because
yeah,
otherwise it will be very dangerous, you know?
yeah. That's a thing that I learned after some cases, and I think that this is a good tip to
Yeah,
say
yeah,
to
absolutely.
yeah, because at the
We all
beginning
learned.
I
We all
was
learned about it. Everybody who does this surgery learned it in the bad way.
yeah. So another good point is to use the in Spain, in Spanish it's T-scan, that is this scan that it's small.
Yeah.
Um, this is a good thing also to know, because the bigger one is uncomfortable.
Yeah, I think it's you know, you have a small space, and you hold the small fragment, and you put the key wire, and you want one shot. And if you have a big C-arm, it takes a lot of place, and you know, you don't know if it's still sterile or not, you know. And the small one is the best. I think in hand surgery is the most useful type of X-ray device.
So are you using for fractures, also for malunions, for acute instability? And what's your option for chronic instability?
So when you treat a chronic instability, it's very, very important to know what is the cause of the instability, because we have different group of ligaments, you know. So our capsulodesis address really good the dorsal ligaments, but not the volar ligaments, you know, or the ulnar ligaments. So we have a lot of types of devices. Like the capsulodesis is very good for the dorsal ligament steer. And when we have the ulnar ligament steer, we can use a suspension device like a tightrope or something like this. It's also very useful.
So you have some questions in the
Yeah.
chat. I don't know if you could check it.
Yeah, wait.
So the first is the quantity of strength that you are using for the
Traction?
arthroscopy. Yeah, with the traction.
4
yeah.
kilos.
4 kilos, okay. And do you have experience with the nanoscope from Artrex?
Well, I tried it once, but I don't have it in my hospital. It's nice. When I tried it, I found it very flexible, okay, which it can be good for in some ways, but also very difficult in other matter because we are used to shove our scope to also create space, you know, and I found the nanoscope was limited in this, okay, and there is also a different angle of visualization, so you need to be used to it, but it for sure it will be a device for the future. Or
yeah. You have also a question from Veronica itself. She's from Mexico.
okay.
And she's asking you if for these cases of malunion that you have, I think that a fragment that it's not viable, maybe if it's an option to remove it.
Okay, so I don't have experience in a necrotic fragment, but when you think about small fragments, you think about the JEDA 3 classification, in which you have a small fragment but a dislocation. So I think in the JEDA 3, the main thing is not the small fragment, but it's the dislocation. In the other types of Bennett fractures, you have good fragments, okay?
Mm-hmm.
So I don't know. I don't have actually experience with a necrotic fragment. I can think about only the JEDA 3 type because you have a small fragment associated with a dislocation, but I don't have experience with it.
This is an interesting question from Melissa Bonilla. She's from Panama. You could read it because it's in English.
I don't. Melissa? Melissa, okay. Yes. Do you consider adding a suspension system or in a small avulsions fractures? Okay, so I want to stress this thing. With arthroscopy, we can check the stability of the fixation and the stability of the joint, okay? And in no case we stabilize the joint by putting a wire between the first and second metacarpus and by putting a key wire between the trapezium and the first metacarpus. So actually, if it's stable, okay, we don't do anything, okay.
And if it's not unstable?
And if it's unstable, it depends which are the ligaments that are ruptured. If they are the dorsal ligaments, we do the capsulodesis, okay, and we don't put key wires. If it's the ulnar ligaments that we see that are not good, we put a key wire between the first and the second.
That's great. That's great.
Okay.
Very clear.
And I think that it's a good advantage with arthroscopy. And I think that the article of Mireia was very nice in getting a good vision of the ligaments and what can you see, and it's really an easy article. It's easy to understand and to apply it. So I can give you the advice to read this article. It's a very good article.
That's great, because at the end we need clear concepts. So I could see that Ricardo is writing in the chat. Dani, ¿puedes hacer que Ricardo Luchetti sea co-host por si quiere decir algo, que él también tenga la posibilidad?
Voy.
So, Lucian, you have also another question from Juan Varela. He's from Spain.
Yeah, Juan is, I know him. He's a very nice surgeon, great surgeon. We speak a lot.
He's always speaking with everybody. I don't know if he works or only talks.
No, I think when I speak with him, he's in the operation room. So I think he works.
Yeah.
I don't work. You work, mate. I listen to you. I listen to you.
Great. So
So he's asking
the
about
key wires, we leave it normally in out of the skin, okay? And we take them off in the office, you know, and we show the patient how to clean them, and he cleans them, and it's no problem.
But you could see that Juan is very, very clever because he's asking about threaded or smooth one.
Smooth, absolutely smooth. I hate threaded key wires, okay? I really hate them. I know that they can give you compression, but when you put them, okay, they don't go, you cannot change the angles easily like smooth key wires. So sometimes I start to put the key wire. I have this experience from the scaphoid, okay? Sometimes I start to put the key wire, and I want to change like 3-4 degrees, and the threaded ones don't permit you, so I don't use them.
Yeah. You have one shot.
Exactly.
And also after that to remove, it's not easy.
It's not easy. You need to go like this in the office for 10 minutes.
Yeah. So I don't know if Ricardo Lucchetti wants to talk or to share some
I don't
experience.
know. I will. Ricardo?
Hello. Hi, Mia. Ciao.
Hi, Ricardo.
He's the master. He's
Well,
the master.
No, I'm
Yeah.
just a surgeon.
Yeah, huge honor to have you here.
We call him the father of modern
Lucian.
wrist surgery in Italy.
Compliment,
So,
Lucian. Very good talking.
okay, so the idea of the arthroscopic treatment was of Ricardo. He's older than me, but younger than me.
Yeah.
So he's
The story is that in 1995, I was in a course in Rosemount in Chicago. And my teacher was Richard Berger. We discussed about the TM joint because it was not included in the course. And 3 to 5 months later, I published in Italian language together with him a paper on the arthroscopy of the TM joint. Before of his publication at the time, some years later.
so it's
and
91.
I started working on this subject.
Yeah. I love this kind of stories. I love
33 years ago.
Yeah.
Yeah.
Not one. Not
That's
one.
good. So do you want to share something more about the technique or some trick or?
I want to say that when I do the arthroscopy of the TM joint, I don't use 4 kilograms. I use only 1 or maximum 2 kilograms because it's too much for the small joint, and this is enough to opening the space and reduce the fracture. Another trick is I used to, before using the screw, I use 2 key wire. Both block the fracture. Then I remove one, I put the screw, and then I remove the other one key wire, and then I put the last screw.
Very good trick.
Only simple method.
Yeah. But that's true. This is important. So you are doing the traction only from the thumb.
Yeah, absolutely.
Okay. And you are doing. And you are using.
It's important to have another doctor that help you because you need to move the wrist in front of you. You have to work in the dorsal side, and it is very difficult. You need to work to supinate it, the wrist, and maintain the position.
And do you prefer to use the shoulder traction?
Normally, because I started from the beginning when I have no traction, only the cyclitic put the cord up to the floor, and then I make a traction like this without
Yeah.
nothing.
As Dr. Piñal also uses this kind of traction.
Yeah.
So
in the just to remember you, in the 1994, 95, I was in Chicago in Rosamond, and I met and did a picture together with Alex Badia, Orbe, and Pinal. We stayed together for 3 days.
wow.
1994.
I wanted to see this picture.
I will show you. I have it.
Yeah.
Oh, that's great.
You can do it.
Okay, so thanks to both. That's spectacular. So I wanted to have you again talking about this technique that we were talking about this osteochondral graft from.
Yeah, absolutely. It will be great.
Yeah, I think that this is very important because it's a thing that.
Here's the picture.
Ah. Wow.
Alex.
Wow.
It's not in the front, but it's the same.
This is a story.
Yeah, story, yeah.
Wow. Okay. So
yeah, sure, Sergi. It's really an honor for me, and you know, it's very important that you know we Italian are also Latin, so it's very important for us also to collaborate with the Spanish people, the Spanish surgeons, and the South American surgeons, and more we share, more we know. No, it's very important.
Yes.
And the thing is that it's a cheap technique, and without screws, without nothing. So it's a thing that they could use also in Latin America. So I think that this is very important to share.
Absolutely, we'll speak about it.
Yeah,
no problem.
Okay, so thanks, and see you again in some weeks.
Thank you very much, and thank you, Ricardo, for joining us. This is our shirt of the Wrist Academy, our research group with Riccardo Lucchetti and Andrea Zei. So
yeah, some weeks ago we have also a Zei here.
Yeah, we were connected, you know. We watch you, Sergi. We follow you. Don't worry.
I am very happy because this is historic for me. It's very nice to have you and also Ricardo. So I am very happy with that.
We are very honored to be here and to collaborate and to share. And you are doing a great thing with the webinar. They are very interesting. And I saw also when Correa speak and Alex speak. So it's always very nice to see them.
Okay, thanks.
Thank you very much. Ciao.
Thank you, Ricardo.
Bye.
Very close friend. Ciao.
Bye. Thank you.
Bye.